Hey, Bolo.
Hello, hello. Hi, everyone.
Oh, you're monitoring. Okay. Finish. Hey, Alberto.
Hey.
I see you. Let's see a
Okay,
ball.
let me change
Something.
the camera.
Okay.
Okay. Hey, how are you? Hi, everyone.
Okay. So, Bolo can hear you.
Hi, everyone.
Okay, perfect. Just gonna make sure that everybody can be listened. Oh, are you in the office?
Who, me?
No, Bolo.
Oh,
Oh, you make a copy. The all office. Oh my goodness. That's a good idea. I should do that. I should go and take a picture. That's nice. Oh, memories. Okay. So Alberto Bolo, we're having interpretation services, and I was asked to remind you to speak slowly because everybody tends to speak faster than me, and everybody who's been presenting. Even in the plenary, there was like a presenter who was talking very, 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 very fast. So, okay. I am going to start the Facebook Live like in like 2 minutes before going live. It's already recording.
You're doing the slides?
No.
Oh.
I'm going to go Facebook Live.
Oh, okay.
Still a little bit.
Yeah, just to give an extra plug for speaking slowly for the interpreters. I imagine a large amount of the audience will be listening in Spanish. So just remember that when you speak quickly, that means that the message that the Spanish speakers are receiving might suffer. So just think of the audience, not so much us, but your audience. Make sure to speak slowly so we can get every detail of what you're saying.
okay. I guess with my accent, English accent, everyone gonna understand everything.
Megan, what do you say? You are already an interpreter, right? Yes. Yeah. So, what was your question? You were.
So we have 15 minutes each, right?
Yes.
I'll try and do it in a way that it's so as it was said, our participants are able to also get the information.
Yeah, I have 14 slices, not counting all the information that I have to speak about each slide. So hopefully 15 minutes could be enough.
Oh, no, 2 interpreters. Oh my God. I'm going to, I still have time. I'm going to, I don't know if Megan, Emily, I'm going to stop the interpretation and I want to start it again. Okay. Yes. Okay. Interpreter. Interpreter. Spanish. Megan. Start. Okay. Are you both now interpreters? Yes.
I think the problem was that Megan's monitoring device keeps getting assigned as an interpreter too. I'm not sure what tech issue is going on.
Are you an interpreter right now? You both are interpreters right now.
We're
Okay.
both interpreters, and I think the third device is also an interpreter. Or is that fixed yet, Megan? I don't know if you can give a thumbs up. Not yet. Okay. It might
only
be an
have two.
issue. You only have two on there?
Yeah, interpreter one and
Okay.
interpreter two.
It might be an issue on our end then. But yeah, so we're fine. I think the interpreting on the settings on your end are fine. We just need to figure out how to get Megan's monitor device separated. Thank you.
Okay. It's not, I mean, on my end, your monitor is not assigned as the interpreter.
Does anyone have the link that participants will be receiving?
Sorry?
Do you have the link that participants will be receiving? I don't know if you could put that in the chat. Maybe Megan's monitor device can join as a participant.
Let me check if I can do that.
Thank you. Sorry to add these extra hassles right before we start.
Should be at, okay, you can go here. If you go to the link, latinoace.org reunion, it will take you to the website of the conference and you go to this third day and you'll find and then you can register. Okay.
Thank you so much.
Okay, we're about to enter, and I'm going to start the webinar exactly at 1 o'clock, and we're going to give like 30 seconds so the rest of the people gets into the room, and then we start. Okay. No sé si son las alergias o estoy resfriado. Este mono. Okay, we'll start now. Welcome, bienvenidos. We're giving like 30 more seconds so the rest of the people can enter the room. First in Spanish, buenas tardes, bienvenidos todos al seminario. Las personas que quieran escuchar el seminario en español pueden utilizar el servicio de interpretación que tenemos activado. Para esto tendrían que ir al menú, a la parte de abajo del Zoom, donde ven un símbolo como un globo terráqueo que dice Interpretation. Ustedes tienen que apretar ese icon y van a tener que escoger español, si quieren escuchar el webinar en español. Y eso es todo lo que tienen que hacer. Y escuchar el intérprete, no a la persona que está hablando. Si tienen alguna pregunta, me lo pueden hacer en el chat. Welcome everybody again, and thank you for being here today at the Reunión Latina Virtual Training Institute, day 3rd, Advancing Public Health, Our Health in Times of COVID. And today's webinar session is titled Tailoring Strategies, Successful Navigation Models. This session is being recorded and will be posted in the webpage of Reunión Latina. During this pandemic, COVID-19 has, and turning most of our jobs virtual, organizations have been pushed to tailor our patient navigations models. In this session, we will discuss best practices from the CIVA department and the direct services program perspective. Our presenters today are Bolivar Nieto, Director of Civil Operations, Hands United Latino Commission on AIDS, and Alberto Medina, Navigation Manager at OASIS Latino LGBTQ Wellness Center at Latino Commission on AIDS. So each one of you are going to have 15 minutes to present, and at the end, we're going to have a section for questions and answers. So I ask the audience to please write your questions and comments in the Q&A box in the lower part of the screen. Okay, thank you. Bolivar.
Gracias, Luis. Thank you, Luis. And it's great to be here at Reunión Latina. I'm gonna start and share my presentation. So good afternoon again. It is great to be here with you on this Friday afternoon. I've been given the task to do the introduction on what is meant when we say tailoring strategies and how this tailoring can lead to successful navigation models, especially during the COVID times that have pushed for innovation, to being able to continue providing services to our communities, which, you know, since February of 2020 has included also information about COVID. So the objectives that I have for this first part, because my colleague Alberto is gonna really engage and talk about the actual implementation and the hands-on part of it. I am just going to review the distinction, if there's any, between tailoring and adaptation, and how both can be used sometimes simultaneously. A quick overview on what is the HIV navigation services strategy that it's proposed by CDC, and that we as CIVA providers provide technical assistance on. And I am gonna provide an overarching example of HIV navigation services as a foundation for HIV services integration through tailoring and or adaptation that can be that can fit the organization structure, the population or focused population being served, and the services provided, including a virtual-based service delivery. My presentation will be broad in scope. And as I mentioned before, my colleague Alberto will provide and share how OASIS has approached the tailoring of the strategy and how they are being able and are providing services, overall services, including navigation. I start with establishing foundations, and this is background and concepts defined. So context and a solid foundation on concepts for me are essential to enhancing our capacity, and it moves us forward in terms of thinking on what we can customize, tailor, adapt the different strategies models that are out there, even interventions when it comes to addressing HIV. I start with the overall one, adaptation, and I put in this part in parentheses and tailoring. This particular one comes from our SIBA glossary, which was put together in 2016. And it really describes adaptation, not necessarily tailoring. You won't see this in this glossary. So adaptation, as you see here, is stated as a process of modifying research-based interventions to meet the needs, priorities, and resources available to an agency. Adaptation may involve modifying an intervention, and I can place here a strategy too, right? And I focus on modifying because this is the tailoring part, because it's not competing or contradicting what with the core elements or the internal logic of the intervention or strategy. So it's sort of like the core elements of an intervention stay intact, and in the case of HNS, that you will see in a little bit, the sequence of it stays intact. There's modifications throughout. It could be about technology, and we'll see that in a little bit. And the intervention is adapted to fill the cultural context in which the intervention will take place, the specific individual determinants of risk behaviors of the priority or focus population, and the unique circumstances of the agency and other stakeholders. Then we're talking about what they can be also called kind of like this reinvention. So it's kind of like really adapting these core elements or this internal logic or sequence to be able to feed the need in a very responsive way of the population that we're serving. So this is sort of like the concept and the foundation of going into this tailoring and adaptation. The cultural context that I just mentioned before, in which an intervention will take place, the individual determinants of risk behavior of the priority focus population, and the unique circumstances of the agency and other stakeholders, means that to embark in modifying or adapting strategy, we need to be mindful of the provider domains. And here we're talking about cultural competence, right? You have the concept here of being a set of congruent behavior, attitudes, and policies that come together in a system, an agency, or among professionals that enables effective work in cross-cultural situations. The other one that we need to be mindful and aware and exercise as we do these tailoring and adaptations is cultural humility. This is a lifelong commitment to self-evaluations and self-critique, right? Revisits power imbalances in the client-provider dynamic. And the last but not least is responsiveness, so cultural responsiveness. And this one targets the services provided to the client at various levels of the organizations, from staff, programs, administrators. So as the arrows suggest, the domains function together in an ongoing and continuous process, like the gears in a clock. There is no set point where one domain ends and another one begins. So it's a continuum and not necessarily steps. So being competent means that there's a constant culturally competent. That means that there's a constant reassessment and self-assessment and self-evaluation and critique of that cultural humility. And how these two then inform our responsiveness, cultural responsiveness in the way that we deliver services. Being an organization that is cultural competent, whose staff exercises cultural humility and provides services in a culturally responsive way to meet the need of the population served, requires an ongoing dynamic process. These provider domains constantly inform each other, shaping service delivery. So when we think about tailoring and what this will mean in the times that we're living and who is the population that we're serving, then we need to also think about these provider domains. I have a different graph to show this in a more intersectional way. And this is, the internal and external processes. So the distinction of the two concepts in both clinical and is both clinical and complementary for work of CBOs. And when I'm talking about cultural responsiveness, as you see, the foci of culturally responsive services go in your vertical axis, whereas core elements of cultural competence goes in your horizontal axis. And you see cultural awareness, cultural knowledge and behavior, health, and cultural skills development as part of the core elements of cultural competence. And in the vertical axis, individual staff level, clinical program level, organizational and administrative. And then we see different, kind of like we go into the intersectionality in terms of, we're talking here, it provides race, ethnicity. We talk about also gender orientation, gender identity, sexual orientation. It says here drug culture. So where culturally humility centers itself, and I'll put it here, cultural humility centers itself on the lifelong process of growth of these two, and learning the self-evaluation and self-critique to address power imbalances between the provider and client. Cultural responsiveness centers itself on the capacity of an organization or system to respond with patient-centered care. So when we're thinking about adapting or tailoring our services, it's this respond to our being responsive to in a way that is patient-centered, keeping in account varied social and cultural factors experienced by constituents, our priority or focus population, that may affect positively or negatively engagement in care. The three-dimensional model that you see here it was developed by SAMHSA and provides us with an applicable framework. And I just mentioned what you see in along the X and Y axis. The volume of the model, the cube, represents the interactions of these according to an infinite number of characteristics of the population we seek to engage. So when we talk about intersectionality, who are we engaging? Who is our focus or priority population? And in terms of these intersections of both culture groups, ethnic identity, and so forth, life experiences. Another example of how the responsiveness framework is applicable in our work, it's about the structural, the 3 A's of a structural intervention. So the availability, accessibility, and acceptability. all that is needed for a successful and effective structural intervention. We can relate availability to cultural competence, accessibility to cultural humility, and acceptability to cultural responsiveness. In other words, what makes your services available to your consumers at the individual level, at the program level, at the organizational level? What makes your services accessible to your consumers at the individual level, at the program level and organizational level, and what makes it acceptable? This is an example and it comes from preliminary recommendations regarding factors supporting the use of cultural adaptation and individual tailoring. So we see that the two particular distinctions here. And the distinctions are based on what we see is the group, the cultural group is homogeneous, or is it, and this is the cultural adaptation. So theory in research here demonstrates, as you can see here, that the collective values across individuals within a cultural group, and this is for a treatment. So if therapists lack cultural competency, skills, experience, or training, then this needs to be emphasized and enhanced. When it comes to individual tailoring, if the group is, the cultural group is heterogeneous, so diverse, right? An individual's social, cultural, historical, and unique experience may differ from those of the other groups. So going back to kind of like that intersectionality, and then how we approach our services in a very when it's very individual, and navigation services is various individual versus potentially having a different intervention that it's more group. So the group might be, in a way, certain aspects of it might be a little bit more homogeneous. And we focus on that may be the differences that may exist, however, acknowledging this. And I'll continue faster. This is the HIV navigation services model. You see the different steps from preparation, which is key because this is your inventory, and establish professional relationships, to recruitment, initial contact. There's information about HNS, eligibility, readiness to engage in HNS, engagement in HNS. Key thing is building rapport, to know barriers of accessibility and availability and acceptability of services, and establish expectations. Number 4 is something that continuously happens. This is the navigation. So you resolve barriers, support, action plan, and it comes back to the next one, right? And number 5 is close the case, conduct the final assessment. Sometimes this happens or not in an organization. For the goal of navigation services for people living with HIV is to be fully engaged in HIV care and treatment. For people not living with HIV who are at high risk, to be fully engaged in HIV and STD prevention services. And overall, for self-sufficiency, so increase that self-sufficiency for our clients, participants, to be able to access and use care and prevention services on their own. So enhance their capacity to do this. Eligibility criteria may differ, but for persons living with HIV, according to the particular intervention, is diagnosed with HIV and not fully engaged in care and treatment. And for those who are at risk, not living with HIV, is recent HIV negative tests, and any of the following, maybe condomless sex, with a partner who is living with HIV, an STD in the past 6 months, and other. But this is kind of like the eligibility criteria as they put it in the intervention, not necessarily has to be of the organization. The organization may have a different eligibility criteria. Have some examples of adaptation and tailoring. We talk about intersectionality. So reimagining the sequence that you saw for a particular priority unfocused population. So when we saw that cube in that responsiveness, who can we do how this HNS would look like for this particular priority population. We may need to add something else. We may need to decrease something. So that may be an adaptation. Whereas tailoring, we need to maybe look at language justice, for how the strategy or intervention is being implemented. Not necessarily changes of the strategy. So technology in adaptation may be adding steps to the current model. Everything is kind of like changing that core element or sequence in this case, but also looking at the tech divide. So tech divide means that the gaps that exist in terms of accessibility to technology and or readiness to use technology. Similar with tailoring is implementing as is. But again, thinking of the end user, who is accessing technology, who has access to the technology. And then it could be, as we saw it in the description of adaptation, focused resources can be a way of adapting an intervention of HNS, specifically for substance misuse only, and may require changes in the steps in the sequence. It may be a specific model for MSM only in terms of resources versus the availability of resources for a segmented population within the same risk focus. For example, young MSM versus adult MSM, and the resources needed here. Adaptation would be removing components of steps versus combining strategies would be a tailoring, like, for example, engagement and recruitment versus removing eligibility or readiness for HNS, and you just do it. Here's a quick example of a process chart, and you will see HNS can have many different components here. And this is actually for self-testing. It can start with the intake, and it can start even before that. It's how you use HNS as your foundational for integration. And this process chart, then you can see it, for example, here in a more kind of like integration of, this is what I do on recruitment, venue-based partners, social media, condom distribution happens in all these aspects. Then there's testing. And then we have, you see, HIV navigation services for both, high risk negatives or people at high risk not living with HIV and people living with HIV and what it's provided. And you see a core competency that is needed from testing to all these strategies and intervention, and that's motivational interviewing. So to end, and I know I'm a little bit over my time, recommendations and tips. Remember, one size does not always fit all. Let's think about what we mentioned about cultural responsiveness, the intersectionality. Let's look at language justice as well. Segmenting priority focused population is key to adapt and or tailor the strategy with the community's input. Resource needs are different depending on the population that you are intending to reach. Look at those. Think of the end user when it comes to incorporating technology. The technology divide that exists. Not everyone is comfortable with technology for certain things or cannot use technology for certain things. Monitoring and evaluation, the implementation of your new adapter or tailor strategy is a must. It helps fine-tune the strategy and fit internal and external to fit the internal and external resources as well as meet the needs of the community. When you adapt the strategy, then changing these core elements or logic, it may require additional evaluation to determine if the new model is effective. And remember, there's SIBA providers nationwide that are available to help. This is, we are the Commission in the South. We are with Latinos in the South. This is our website and some of the resources here. And I pass it to my colleague, Alberto.
Hi, Bolivar. Thank you. Let me share my screen. Well, my name is Alberto Medina, and I'm the Deputy Director of Access to Care and Navigation Manager at OASIS. Who are we? Well, OASIS Wellness Center is the best center for Latinx community and young people who want just to come and chill and have some, either if they want to have some coffee here, they're so welcome. If they're looking for um, resources that provide testing or just simple as a safe space that they want to be at. OASIS Wellness Center was founded in 2015 to provide comprehensive services and support and foster the health of the Latinx community in their lives. We work with people for all walks of their life who are share a common goal in bettering their sexual life, mind, body, and soul. What we do, Oasis Wellness Center offer, different kinds of services for all our community. We have a program that we call Muerte, that it's for Latina women, cisgender, transgender, and bisexual partners. We have a P4 program that serves for all gay men, bisexual men who have sex with men. And we have Inspire program that offer harm reduction program for men who have sex with men. And we provide all these resources. We provide testing, inside and self-testing HIV. We provide linkages to PrEP and HIV care, depending on the population that just come to our office. On March 20, I think March 20 was really hard for everyone. It was a time that we had to close our doors to protect our community and protect the staff from COVID-19. Uh, fortunately, we were able to transition to a telehealth counseling in matter of day and continue delivery of services that our community needed. Responding to the need of the staff. As you know, OASIS Wellness Center in part of the Latino Commission on AIDS, we create decompression meetings, which help us to meet with all and talk about the different matters of what's going on in our, professional and personal life. So we usually meet every Friday to discuss about what's going on during the week, how we were feeling mentally and emotionally with all the issues that we were having back then in March. That helped us a lot to be in contact with the staff member and share our experiences and learn how we can process and how we can deal with it. We start working from home. Since we closed the door, we start working from home and keep providing the services to our community, for being safe from COVID-19. After we start working from home, we start implementing the hybrid work model, which means in July, we start coming 1 week to work from the office and open our doors for our communities, and 1 week from working from home. And we standardize our hours. Before March 2020, we were working 4 days a week from 12 to 8 p.m., including Saturdays. And we start working with new shift, which means that we change from 12 to 8 p.m. and it start working from 10 a.m. to 6 p.m. to provide more services to our community. Responding to the need of our communities, increase accessibility. Because everyone was a little bit afraid to go outside and be exposed for COVID, we start working, as I mentioned before, with telehealth counseling. We start relocating funds where possible for nutritional items. We start providing virtual incentive. One of the programs that I just mentioned, that it's Inspire program, we start help people to get some incentive when they need it. Emergency COVID support. We start providing all the support that people may need, such as virtual mental health. For virtual mental health, we start working really close with the NYC Well, which were offering services in Spanish and English by phone calls. We start providing access to food pantry, and we start working really close with some food pantries here in the city, and also help people to apply for emergency home food delivery, and also providing the hotline and services for people who are suffering for domestic violence. And for some folks that they were afraid about or have any legal services because they were be kicked out from their home, or just they are looking for any kind of asylum process, we start working really close with the legal services on NYC and other resources that we have. When we start working by telecounseling, we keep the same professionalisms and support as we provide in person. We keep that in mind for all this stuff, that we need to provide the best services as if we were providing it in person. We were mindful with the client's expectation and ideas, and how telecounseling process will look like, may different from what our staff were expecting and our founders. Also, we bridged the expectation and gap to meet the client and what they were looking for, meet the expectation, and also meet all the programmatic, professional, and legal requirement as we met, such as like HIPAA form from New York State. And go an extra mile for providing services to our clients. When we are talking about do the extra mile of the services, it's in some cases, some clients, they just were able to talk with us after 6 p.m. So we were working for those clients and providing the services that they were requiring to, moving our time from work to, try to provide the services and link the clients or help the client to get linked with the services that they were requiring. How we do that? In our page, that it's OASIS Wellness, OASIS Center NYC, have served the entry point for our community to access our services virtually. We developed the scripts to standardize the communication within all the staff and the clients. We start working in social media one-on-one training, trying to reach out more our community by social media. We start negotiating with founders if were possible, and just provide the services for all the community that they were needing, whatever services that they are looking for. We start implementing, LACOA been implementing the home HIV testing since 2014 through the HERD, Hispanic Health, Equity, and Action Driving Research and Development. And we start, promoting more of these services by, reaching out the clients by social media, help them to get access to home HIV testing. What is the step for virtual HIV counseling? Once our clients or community requests an appointment for home HIV testing kits, they request by our website, oasiscenter.nyc, and we start open the session by submitting. We explore the risks of the client, if they're, how long they were exposed, or what kind of sexual risks the client it's been on. We provide basic education from PrEP, PEP, U=U, HIV. We collect the data to report to our founders. We explore all the basic needs, such as if the client needs access to food, or maybe the client was looking for health insurance, or maybe some clients, they were looking for different supporting services, such as housing services or legal services. We start exploring those needs too. And we encourage our clients to do the post counseling, which means that we meet with them after the first session, either to do follow up in their needs and help them when they get the HIV home testing. And then we request the home testing and we close the session. Promoting and recruitment. We start using all our skills to do social media outreach, like using all the TikTok with this technology, all the flyers, trying to engage all our community to get home HIV testing when some of them they weren't able to get out from the home, maybe they didn't want to go out and expose themselves. So we start promoting our services through social media. And we also start expressing and receiving all the concerns regarding the COVID-19 and how they can prevent when they go out on the streets and they want to prevent and reduce exposure for COVID. The post-counseling under the HIV status network model, we start working with with all the community, whether they are HIV positive or negative. And during the post-counseling session, we can, we help the client to clarify some, doubts or support them through video camera or video call while they get tested, performing, and help them to understand what the results and help them to access to different other resources that maybe they were looking for. Linkage and procedures for the self-harm HIV testing, the essential word that we will help them once they get a positive, either positive, negative result, is try to help them to get links with other services such as HIV care, PrEP or PEP services, or get an STI screening. And during the home HIV testing event, we keep doing the follow-ups through the counselors and explore other risks that they may have and help them to identify if they want to do the next step, either get an STI or maybe get access to PrEP, PEP, or HIV care. What the lessons that we learned? We learned that we need to digitalize all the internal and those required by the founders. That helped us a lot to do the process when we start working with telecounseling. We start training our staff in technology. I'm talking about myself. Sometimes we need to use with some clients that they don't know how to access to Zoom meetings. They don't know how to sign the HIPAA form by phone call. So we start training our staff and how to explain to our community and all our clients to get access to this technology, either if they need just to get by video call through WhatsApp or just phone call, how they can sign those documents required by law that we needed. And be open to the last minute change, providing services by Zoom meeting, by phone call, by video call, either for WhatsApp or which other platform that the client can be access to the services that they were looking for. Weekly meetings, we start meeting with our all the staff to share all the new resources that maybe we just got or unsuccessful stories and common incidents. So we can, in case that these other incidents or some client, they may have the same needs, we can provide all the resources that we have. And do the networking. That was the key to be successful in our telecounseling. Have all the resources that, different providers that we can access for services and work for the community. Well, thank you. This is my information and the information for the director of the program, Gustavo. And I think I go back with Luis.
Okay. All right. Thank you very much, Bolivar, and thank you very much, Alberto, for your presentations. It was very informative. it was very nice to understand the difference between adapting and tailoring, and the importance of cultural awareness, responsiveness, and cultural humility when you implement tailoring and adapting your programs. And also very well description of everything that has been changing OASIS this time with COVID-19. So now we are going to go to the questions of the audience, and I ask the audience, please write your questions either in the chat box or in the Q&A box. There's a question for Alberto, I think. What type of problems or new problems have you, your programs in OASIS noticed during this time that we have living like 14 months already with COVID? And what was the biggest demand, different than the usual demand that you have at your programs, and how OASIS responded to it? What adaptation they need to do?
I think not the biggest problem is, but I think the most common services that our community were requesting at the beginning was for access to mental health during the pandemic. And for it's really hard for some folks that they don't have insurance because unfortunately here in New York, mental health services, some organizations, they provide free services for short times for people who doesn't have insurance. So as the lessons that we learn, it's doing the networking. We start reaching all the providers who can provide these services for mental health for our community for free. And the resources that we got either was for the NYC Well, that was a really good resources that we get. So we start promoting for our community that they can call for free. Also is total confidential. In some other organizations that they were providing mental health services, if the client get linked with or get access with different services, like for example, we have one provider that they say if any client that or any person that you refer to our clinic get into PrEP services or HIV care, they either, even though they don't have, they are not eligible for insurance, they can get access to mental health services for free. That was the main request for our community, I think, and that was a way that we helped them to get access to. You are mute.
It always happens. One of the virtual new mistakes that I always make in these sessions and with Zoom meetings. Yeah, I was gonna say like definitely I think mental health was one of the biggest demands that we have noticed also everywhere. I mean, everybody was calling and asking for services because the confining your home, not being able to go out, the different changes in life was very have a big impact in our health in everybody. So glad to hear that through your networks and your connections, we were able to provide services to the people who were requesting those services. Thank you. I think this is for Bolivar. Is there any specific recommendations for PrEP navigators that might be a little different to the general recommendations that you have given for HNS?
I think that each agency and location, it's gonna be kind of like different. And again, I really go for kind of like the uniqueness and customization of how these services are delivered to the consumer. For example, linkage is a big challenge in these virtual settings, right? When you go to a brick and mortar organization, you go in for an HIV test, and as you are discussing, then you can then be connected to someone who is a navigator who can link them to PrEP, and even kind of like, as I think OASIS was doing it and has done it and potentially continues to do it, it's like sometimes accompany them to the location in which they will receive the PrEP prescription and all that. That's not happening when everything it's virtual. So a lot of the things that need to reconceptualize is how do we do this linkage, and maybe they going with my client participant who's requesting prep to that initial meet and greet with the provider through Zoom, and then I will remove myself from Zoom, so you can kind of like taking or being with them through that process to kind of like address sometimes power dynamics, address questions, and let's address language justice that may not happen, and that our clients may have. Another thing is that, you know, I have learned, and we have learned as a team, for example, at-home testing works for those who have a home. But if it's advertised as home testing for those who may not have a home, then that's something that is not going to encourage them to come in for services. So it's maybe like self-testing, self-HIV testing, and there's many different ways, whether it's like autonomous, as they call it, like the really self-testing towards, or the guided one. We're now looking into, you know, does a provider needs to be present throughout the process, or do I do these automated services in which, you know, linkage can be done by the recipient as well, right? So these are my results, these are my options. I click here, I have the option to talk to someone, but I may have the option also to like continue with like, these are the list of providers in my area. I can do it myself. So remember, HNS is about self-efficacy in being able to navigate yourself through these also services for your own sexual safety. Mm-hmm.
Okay, so what you describe is more or less what you earlier in your presentation said about individual tailoring, like
Yeah.
Okay.
Yeah. Because one of the things that I agree, you know, mental health was one, but also in times of social distancing, a lot of the conversation revolved around sex and engaging in sex. So how is that happening in social distancing times, or is it still happening and then the risk escalated or potentially increased? Maybe not for HIV or for HIV, but also COVID, right? So, you know, we started seeing a lot of information about sexual safety during, you know, social distancing times.
Yeah, there was something that was touched yesterday in the session about mental health, about sex and how people continue to have sex despite the fact that they were exposing themselves to the virus, and how that could be like affecting themselves in terms of the virus, but also liberating themselves about the depression and the stress that it was imposed to us by the virus itself. So it was something interesting to talk about. So Alberto, replying to what Bolo said about home testing, I know you mentioned that home testing was one of the things that was implemented earlier during the pandemic. Compared to previous years when testing was done in OASIS by the testers that you have, the testing this year definitely, I imagine, was lower than usual regular times that we live, right? But when home testing was implemented, do we have a good response from the clients? We were able to do a good number of home testings?
Actually, yeah, it was really welcome for our community because as I mentioned, some of them, they were afraid to get out from their homes and they just want to keep, you know, testing themselves to be sure in case that they were exposed. So we have a really good you know, people, they were really open to access to these new services online that we were performing by telecounseling and offering. And plus that this was free services for our clients, right? They just has to make an appointment. One of the requirements that we ask them is that they have to provide the results, and we receive really good response from the clients, because we were afraid that maybe some of them, they don't want to report the test. That's why we start really promoting the post-counseling to verify. And, for some of them, they say, I'm not sure how to do the testing. So we promoted the post-counseling to help them to go through the process in case that they have any result that they wouldn't expect it. And plus we keep all the other risks and help them to get through the process. So it was really good. We keep serving people and providing services to our community, not only for home HIV testing, but also for PrEP and PEP linkers and access to those services as well. Yeah.
So how was the PrEP navigation service provided in OASIS during this time?
As I mentioned, it's the key for a good service for our community is networking. So you need to know who is next to you and provide those services for our community, right? We have, a bunch of lists of providers and clinics that offer either by teleprep or in-person services. So it's about what the client's needs. If the client, the patient or the client is open to go in person to get all the testing and do the process in person, we have different providers that they still doing in person appointments, or if the client wants to teleprep, we have different providers that they offer teleprep. Those providers, it's for teleprep that we are offering. It's really welcome for students that they are, in home receiving classes and they don't have time to go out. We have some providers that they offer teleprep. So those providers, all the meetings with the provider, it's by video call, but they send to any lab court close by their home to get all the blood work and also the medication. So it really works for us, offering teleprep also.
Thank you. There's a question from Rey de la Paz. He said, it was mentioned that spiritual health was a priority when serving the community. So he's curious about how organizations may help to facilitate more holistic and inclusive spiritual health services and options for their communities. Can you all share some of your experiences and ideas in doing so? Anyone?
Hi. So that's a great question. And what my recommendation goes back to kind of like that initial understanding of who your priority population is and the needs, right? And if the spiritual health, holistic and inclusive spiritual health services and options for our communities needs to be kind of like part of that first phase on navigation, right? Is this a need for our priority population? And if it's such, then how do I incorporate this as part of the different services that I provide? How this is going to be delivered? Do we have the capacity within the organization to do so? Do we need to engage subject matter experts to be able to facilitate these different things? So there's a lot of different mechanisms that need to be, thought about and thought out. And looking at our model in terms of prevention services that are holistic and inclusive. Where does this fit? How do we do it? Can we do it? And if so, how do we then start engaging and facilitating? And remember, I said like monitoring and evaluation, because evaluating will provide you with ways in which you can fine tune that particular service, right? So as you start implementing it, the evaluation will provide you kind of like the data that it's gonna enhance that particular new service or that you're bringing into the mix. So everything starts with, that understanding who your priority focused population is. What are the particular needs in terms of holistic health, inclusive of HIV and spirituality? What do I have? And so forth and so on. So it's kind of like a process.
Thank you. Anything you would like to add, Alberto? If you don't have anything, it's fine.
I mean, it's just with all respect, with the spiritual connection, we respect and we try to, talking about my services to our community, this spiritual connection is also part of who you are, right? And it just be respectful in whatever the need of the patient or the community has, or whether they want to be referred to. So we try to provide all the services and that they are requiring to us.
Okay. So it seems there's some more questions here in the chat or question and answers. So something you would like to add to finish the webinar, each one of you. You have a few minutes, couple of minutes.
I think from my perspective for virtual services, I and more if we are working in the HNS model, the key for this is make a commitment with our community. If we are working with any clients who are required whatever services or whatever needs that they have, it's try to provide these services to reduce the stress that all the community has right now. And you know, listen to them and listen what they are asking for. Not only what we want to provide to them, it's what they are, what is their needs, and listen to all our community and providing the services and help them to go through the process is the key to, you know, to better sexual health, spiritual life, and personal life. Yeah.
Thank you, Alberto. Bolivar, yes.
Oh, my. All right. So I'm going to echo a few things that my colleague Alberto says, options. So we need to look at, you know, the different ways in which services can be offered, keeping in mind how acceptable the way we're offering these, our priority or focus population is, right? We talk about the technology divide and transitioning forms and all that. It's great. Does it work for everyone? So we need to start thinking about, you know, how do we start having this hybrid approach in continuation to having this? Because now, you know, we were forced to transition into this virtual mode of providing services, but this is staying, right? So now it's going to become an option, right? Through virtual settings, we may reach populations that may not want to come to a service or a group session in our office because of different circumstances, right? Transportation, social determinants of health, stigma, but they may join your virtual event. So that needs to stay. So I think that options it's one of the things. Looking at services and the way that we're providing from the end user, is it something for me? Looking at the intersectionality of who we are reaching and the services that they may need through segmentation, as I mentioned before. And you know, evaluation it's key in monitoring throughout the whole process. And transparency. I think that if you cannot provide a particular service and you don't really know who is out there to do this, saying that, it's a way to build in rapport with your client or participant and community members. So, you know, we want to be able to provide everything, but sometimes there's limitations, right? And be transparent about that, and maybe working together and finding something, it may be the way to go. Mm-hmm.
And I'm sure we'll be talking about this again because things continue to change, and we are at a certain point coming out from this completely virtual world that we're living, going into a type of hybrid or whenever we don't know yet. So things have been changing constantly since the beginning of the epidemic until now, and they will continue to change, and everything is new. We keep on learning. So thank you very much, Bolivar, and thank you very much, Alberto, for all your information and the insights that you shared here. And thank you, everybody who attended today's session. And I invite you to participate in the last session of Reunion Latina, which is going to happen half an hour, 2:30. And thank you again. See you next year.
Thank you, everyone. Great seeing you. Thank you, Alberto. Thank you, Liz. Have a
Thank
great
you.
Friday and weekend.
You too.
Yeah, it's a Friday. Thank you, everyone. Have a wonderful weekend.